John is a native of Boise, and he went to our undergraduate program. And I first met John. My name is Trevor Lujan, by the way. I first met John about 3 years ago. He was in my biomaterials class, and he immediately got my attention because he was either asking me a very thoughtful question or his eyes were closed. It was like one or the other. And so I eventually hired John in my lab, and he's worked on 3 different projects. He does very good work. He's an excellent engineer, manages a lot, and it gets the job done. When he's not doing research or in class, he competes in grappling tournaments. So, keep that in mind if you ask him a difficult question before you do. Yeah, it's my pleasure to introduce John.
Thanks, Dr. Lujan, for the introduction. I'd also like to thank everybody for coming up here today, and I'd like to thank the MBE department for supplying the cookies that usually brings all these people here on a weekly basis. So I figured we'd start with a video. Most of the time everybody shows football injuries, but I figured I'd show some guy screwing up his knee in a judo throw. I would play some sound, but there's some profanities that the guy yells after he screws up his knee really bad. So pretty gnarly. I'm sure he's got a little bit more than just ligament damage, but I'm sure there's some ligament damage there. Pretty gnarly. So ligament injuries are pretty common. How many people in here have had sprained something at one time or another? Almost everybody. Whether you're rolling an ankle or you don't tap from an arm bar, you probably sprained something. So what do ligaments do? They basically stabilize your joint. They connect bone to bone. They don't move anything. It's mostly just there to guide your joint articulations and prevent damage to your cartilage over time. Ligament functions completely mechanical in your body. It's just a musculoskeletal tissue. It's basically composed of 2 components, a ground substance and a fiber, and fibers that run through it. So the ground substance is kind of like a jello, mostly made of water, sugar, and fat. The fibers are much stronger. They give the ligament most of its structural integrity, and it's composed of mostly collagen and elastin. So whenever you injure yourself, everyone's always like, oh, rest, ice, compression, and then they send you on your way, and hopefully it gets better. But most of the time you realize, like, you got that tweaky ankle. It never really got better. It's your bad ankle for the next 2 years, and you never trust it again. And that's because the ligament never actually gets back to its full native state that it was before you hurt it. And that affects pretty much all athletes, or pretty much anybody who has a sprain. So what actually happens when you get an injury? The ligament itself actually changes structure completely. It's no longer this nice, highly aligned composite material that's really strong. It's now this amorphous material with fibers running in all these different directions, and it doesn't have the same strength. So that structure leads to this impaired function. It's less strong, it's less stiff, absorbs less energy, creeps more. It's basically just completely way worse than it was before you had the injury. And this can happen, stays this way up to a year later, or multiple years later if you don't take care of yourself very well.
So John,
yeah.
So can you guys direct me on that figure?
Here you can see, screen, yeah. You can see the sham control over here. That's an uninjured ligament. And then all 3 of these are at 6 weeks of healing, 12 weeks of healing, and 52 weeks of healing. They're pretty much all in the same spot. So they really did not get much better over the course of a year of healing in these studies. So what can you do? There's some alternative treatments that you can do besides just rice and hope that it gets better. Some people are doing cell therapies. Some people are doing physical therapy through movement, exercise, painkillers, physical therapy treatments. Some people are doing instrument-assisted soft tissue mobilization, or a combination of physical therapy instrument-assisted soft tissue mobilization. The cell therapies are really expensive, so you're probably not going to ever do them unless you're a professional athlete and you can drop $50,000 because your insurance isn't going to cover it, because there's no real conclusive evidence that it does a lot yet. You can possibly afford a prolotherapy injection, but that's basically just them just putting sugar water into your ligament. So if anybody ever tells you that that's like a super awesome thing, they're probably lying to you. It's about as good as probably going and getting acupuncture. You might have a placebo effect out of it, but you're really not getting much. The platelet-rich plasma is just where they take your blood out and they put it in a centrifuge and then inject a bunch of your own platelets into a different part of your body to hopefully stimulate healing in that area. And stem cells is injecting stem cells into your body. Another option that's a little bit more affordable, it's covered by insurance, but it's much less invasive, no needles are usually involved, is movement or getting some sort of physical therapy. And this is, has shown some better benefits for people because it's very clear that if you don't move your joint afterwards, if you just leave it in a cast for too long, your ligament's not going to heal. It receives no stimulus, therefore it doesn't heal. Why does that happen? Your cells are mechanosensitive. They respond to outside stimuluses that you place on them. The German scientist Julius Wolff first discovered this in bone, where he would see structural adaptations in the bone from changing different loads on it. And that happens in lots of different musculoskeletal tissues in your body. So if you don't use it, your body sees no reason to keep it, sees no reason to strengthen, so it just doesn't do anything. Instrument-assisted soft tissue mobilization. You can see right there, that's an example of a treatment with an instrument that they would use right there. They're usually made out of some sort of metal or plastic. They're pretty safe, non-invasive, and sometimes covered by insurance. And so, it's something that most people are trying out. Clinically, it's been shown to improve ankle pain, chronic shoulder pain, knee pain, and in vivo tests and research, it's been shown to accelerate healing in some studies, as well as increase cellular activity in the affected tissue.
Is that the instrument there?
What? Yeah, that's one of the instruments. There's lots of different shapes. This is just like an example of a shape that they'll use. If you look over here, so basically what they'll do is they take those instruments and they'll rub along your affected tissues and in the surrounding area in the body. And they usually do this for a short duration. They do usually 4 to 6 treatments, depending. Sometimes you go back for multiple treatments depending on the nature of the injury. And they're used for both acute and for chronic injuries. But usually if you really screw something up, and you're not going to go in directly after you've injured. You're not going to get hurt and then somebody's going to go start rubbing on your leg because it's already hurt. It doesn't need any more stimulation. So you have to let it heal enough so that it has some structural integrity, and then they can go in and perform the treatment to hopefully help you heal quicker, back to 100%. So the theory right now is that the functional effect of iStim is just to break up these, they call it adhesions. Your whole body's filled with stuff called fascia that's basically connective tissue that connects your muscles, connects it's in your skin, and when you have an injury, your body is trying to basically protect and immobilize that area, so it puts down more of that fascial tissue. And if you go in with that instrument, it can help break that up and allow you to move, which stimulates the cells, which helps you heal. That's the theory right now. And it makes a lot of sense. It's probably some merit to it, but there's no real quantitative scientific evidence that says that fascia is the only functional effect. This is exactly what iStim's doing. But since it's non-invasive, people don't care. They're kind of using it like snake oil. They're just doing it on everything. Oh, you got a pain? That's iStim. You got I don't know. You got a headache? Well, iStim. Like anything. So what do we know? We know movement and exercise are clearly important for healing, but we don't know the optimal mechanical environment in the tissue that's actually producing the healing. We know that soft tissue mobilization is anecdotally pretty beneficial, but we don't understand what dosage. And when I'm talking about dosage, I'm talking about how often do you do it, how hard do you press when you do it, how quickly do you press when you do it, what direction do you press when you do it. A lot of physical therapists just are kind of okay with the fact that they learned these protocols, but there's no real qualitative data. You can give them a range of how hard to press. So what we want to know is what are the specific mechanical environment that actually produces healing in ligament. So you can kind of see our little research overview here is we can apply these stimuli and see what cellular effect we're getting out, and that will in turn affect the structure of the ligament, which in turn affects the overall function that we're going to see. That's kind of the overarching way we can investigate this. We can look at this, the research structure, in 3 different models. A in vitro model, which takes place outside of the body, an in vivo model, which takes place in animals, little mouse, and clinical, in a clinical setting, in a doctor's office, where you have people who are volunteering as part of the study. There's pros and cons to each one of these. An in vitro study allows for total control over exactly what you're doing to your cells, exactly what you're doing to your simulated tissue, but it's not real tissue, so there's variables that you might not be seeing in humans, so you can't directly transfer your results that you see to what actually happens in the body. In vivo, you're kind of getting the middle ground. You're closer. You have results that are more directly transferable, but it's hard to tell a rat to only walk for 5 minutes a day around in its cage. It doesn't really care what you think. And there's more material variability. You might have like a super athletic rat that has really strong ligaments, and you have one that is just that was never meant to play sports. Just might not be able to cut it. And clinically, you can't. The results are directly transferable, but you can't trust people to do what they say they're doing. Some people eat like crap, and some people have bad genetics. Some people are older than others, and there's so many confounding variables. It's really hard to isolate exactly what you're doing. And we can't really quantify exactly how much better did their ligament heal. We can't cut someone's leg off. That's not allowed in our country. So the 2 models that we're used to investigate this in our lab are in vitro and in vivo models. So that's our goal here, is to present our research that's still in progress for both these in vitro and in vivo models. And part of the advantage of presenting right now is I have all these smart people in the audience that can help me figure out how to do the things I'm trying to do with these models, because we're not exactly 100% of the way there yet on both of these. So where we're at right now, we're designed a 3-dimensional gel type model that has cells suspended in this jello-like substance, and this has the advantage that we can completely understand the mechanical properties of that, and we can change its shape. We can pretty much do whatever we want with it, and we can also know that the deformation that we see in the gel will be the deformation that we apply to those mechanically sensitive cells that we see inside of it.
How do you know that?
Based off of various studies that have looked at the similar type of gel that we're using, and they have looked at different scales of strain measurements, and they have tracked the cellular strains as well as the macro level strains of the matrix, and saw that they were the same across both the macro scale and the micro scale. So we can kind of safely make that assumption without making that whole thing ourselves. It probably took like 20 years for them to make. So here's a short little video of a device that is kind of an example. This is not our device, but this is a device that people make to stimulate these gel type substances. And you can make them in lots of different shapes. This one pulls these little squares in tension, and those little pink things are the gels that will have different cells seated inside of them, and you can adjust how quickly it's pulling and how far it's pulling and things like that. So there's a lot of factors to consider when you're doing stimulation of these cells. Like, what direction are you pushing on it? Are you pulling on it? Are you compressing it? Are you doing a combination of both? Are you pulling it statically or dynamically? How far are you pulling it? What is the frequency that you pull it at? As well as how long do you do it? So in terms of direction, we know that at least in these types of gels with the ligament cells seated in them, you will see the cells produce collagen fibers along the axis of strain that you produce. So if you pull it in one direction, it'll go highly aligned in that direction. If you pull it in a lot of directions, it tries to reduce the stress in all of the directions. So those fibers become basically amorphous and going in all the different directions. So for tension, just for the simple uniaxial tension, we know that to improve the mechanical properties of the gels, cyclic mechanical strain is much preferable to static mechanical strain. If you just statically pull, the cells they will respond a little bit, but then they after a certain point, they don't feel the need to adapt any longer. But if you cyclically pull them, you get better results. Pulling them at lower peak strains gives them enough stimulation, but doesn't actually pull them too much to where it is detrimental to their growth. Pulling at lower frequencies has been shown to improve the healing better than higher frequencies. And intermittently straining them is better than continuously straining them. So if you were to take the cells and pull them for 24 hours a day, you're not going to get, it's like if you go to the gym and you work out every single day and you never take a rest day, you never get a time to heal. It's the same thing with the tissue, so it kind of makes sense. You can't pull them all the time. They need pulling and rest and pulling and rest, and they get the best results out of that. In compression, there's some evidence that compression does help for activating fibroblasts, but high levels of compression, if you compress them too much, it just actually hurts the cells more than it does help them. So we have all this information about pulling and pushing and strain directions, but what we don't really understand is what is actually happening to the tissue and the cells inside in terms of the specific deformations that we're applying. And the reason this is important is because what actually signals the cells to do and to make those changes to the tissue are these stretch-activated channels in the cell membrane. So the cell can tell when it moved, when it's changed shape, when it's been being compressed, and when it's moving. And without understanding exactly what's happening to the cell, we can't truly understand what is actually causing the healing response in the tissue. So as mechanical engineers, we can look at deformation in two parts. Pretty much any type of strain can be broken up into these two components. A deviatoric component and a dilational component. So you can see on here, if you take this and pull it in tension, you'll probably get some sort of rectangular cube like this. There's a component of this deformation that is just changing the shape of the object and not changing the volume of it. And then there's a component where it's just changing the volume of it. And these are important because we use the dilational and deviatoric behavior materials to describe pretty much every other material that we know a lot more about in engineering. And we base a lot of our failure criteria specifically on deviatoric stress in terms of this max shear stress theory as well as von Mises. They're totally based off of what shape are you deforming the object to, not are you smushing it into a smaller version of itself or pulling it into a bigger version of itself. Just give me a second here. A lot of talking. Another thing that makes deviatoric stress a good thing, deviatoric and dilational, a good thing to investigate is that in 2D cell culture, where they just have a little layer of cells, which you can see right here. So if the cells are just sitting here on a layer, they have no surrounding tissue, they're just all alone. They will run fluid over the top, which creates a purely deviatoric stress. It's pure shear over top of them. And there's a lot of research that shows that that increases the activity in those cells. But they don't do this a lot in 3D models. And so you don't really see what would be the tissue effect that you see in the extracellular matrix after applying these shear stresses. So how do we decouple volume versus shape? And if this, for the sake of that discussion, we can look at some more circles and some stress elements, and see what theoretically what type of deformation are we going to get out of those. So if you applied purely pressure to the tissue, if you knew a way to do that, you wouldn't really get a Mohr circle, would you? Because there would be no different stress state in any orientation, because you're pressing on it in the same way everywhere. So the deformation will be purely dilational. If you were to pull or to push on these, and you weren't to constrain the outer other sides of it, you would see that there's both a shape and a volume change in these ones. If you're to push and pull in exactly the same magnitudes at the same time, you can get a Mohr circle that's centered around the middle, which is a purely deviatoric stress state, which is kind of a little bit counterintuitive first, but when you pull and you push, you're actually not changing the volume of the object at all. You're only changing the shape of it. So this is kind of similar to what you're doing when you're pressing down. You're creating this really high shear, highly deviatoric environment when you're doing those soft tissue mobilization type things. And you can see that, if you remember, if you orient an element slightly differently, you see that that's actually putting it in shear as opposed to just putting it in those normal stresses. So if you can kind of make that leap of, oh, you're pressing down and the ligament has some natural physiological tension in it, you're creating that high shear environment when you're doing that. Naturally, it's way more complex than that probably, because there's other things in there involved. There's probably an added shear component because you're moving along the tissue at the same time, but that would just make more shape change. So it still leads to, deviatoric is probably the big driver of healing in the ligament. But this only really happens for a short duration, so there's that variable that we have to consider as well. This pure shape change would only be happening for the duration of your treatment, and then the rest of the time you'd just be in tension because you're under physiological loading. So what was I just blabbing about for the last 6 slides? Why does any of this really matter? The whole idea we were trying to go for with this is we want to know, again, how to decouple dilational and deviatoric. If we could apply these loading conditions and produce these deformations and then see mechanical changes as a result, we could say what is the effect of dilational, what is the effect of deviatoric, and what is the effect of both. Does it matter at all? And with, and theoretically you could do some sort of in vitro type I-stim reproduction. So this kind of brings us to our hypothesis that shape change is more important for healing than volume change. That's what we think based off of the previous research and what we just described here. And if we could answer this and apply those different stress states or strain states, we could determine one, if the functional effect of I-stim has something to do with the stress state that you're placing it under, or if it just has to do with fascial adhesions. And two, this would help with tissue engineering. If we know this is exactly the stress state you want to put cells under to make them strengthen these gels the most, then you can tell that to somebody and they can design devices that put those tissue constructs in that stress state to help them produce better healing and better structure. We'll move on to what we've done so far. We have currently made these collagen type 1 gels, and we've used these cruciform shaped molds to make these, as well as these stress-free shaped molds. Now, there's a reason that we do that, and I was talking earlier about the property of these gels that if you strain them in a certain direction, you see fibers that align in that direction. By making a cruciform shape like that, the uniaxial arms will be under a small amount of static uniaxial stretch, and the center will be under a biaxial stretch. So if these gels are acting like ligament, then we would hopefully see fiber alignment according to those two. And the reason that there's that level of stretch is because of these glass rods in here. The collagen actually adheres to that. It doesn't adhere to the mold, it doesn't adhere to the culture plate that it's in. It only adheres to the glass. So it contracts along that and puts itself in a little bit of a static stretch. While these free-floating ones just sit there and they do what they do. We also need to be able to quantify what the heck is healing. I keep talking about better healing. We can look at the processing, so how many cells are alive, are there, and what genes is it expressing? Is it expressing the same genes as regular ligament would? As well as collagen fiber alignment, so the orientation of those fibers, as well as the composition, what is it actually made of? And the function being the elastic modulus of the tissues. We can look at these in lots of different ways of all these biological things that I don't really know a ton about, and mostly the people in the BRC help us with this, which would be like looking at the Pathology, which is those purple slides, and we'll show a picture of that. And the two ones that we can help a lot with are the confocal imaging to quantify that collagen structure, as well as the digital image correlation to look at the linear modulus. So when it comes to actually stimulating, my GIF working? My GIF's working. For uniaxial stretching, we can use a device, something like this. Ganesh has or Dr. User has a device called a Flex Cell, which basically uses these flexible silicone membranes, and you can culture your gel in here and have it adhere to some anchors in there. And as that pulls, you can apply uniaxial strain to the cells, and you can tune that to whatever type of stimulation you're trying to apply. So that's just an option that we're considering for actually applying that stimulation. Some other results, we have the histology that I was talking about, and we saw good cell viability, and we also saw the cells aligning along what the axis of strain. So you can see this is like just the number of weeks of incubation and the stress state that it's under, and you can see the cells elongating in the uniaxial, which is what you'll see in actual ligament as well, so that was good. Here's the confocal images, and these are pretty cool because we can actually use the fast Fourier transforms, and Ricky, I don't know if you remember Ricky Morrill made a program to actually put these numbers down here, and those tell you how aligned is it. So the higher the number, the better alignment that you'll see. And you can see that in the photos too. The uniaxial is clearly more aligned, while the biaxial and the stress feed look pretty similar in that amorphous structure. So in composition, the big player here is collagen type 1. There's lots of different types of collagen that I don't know a ton about, but I do know collagen type 1 is important. And the biaxial and the stress-free are showing the most collagen type 1, which is indicating that they're probably most similar to the healing ligament. So why is all that important? The reason we did all that is because we need a baseline to compare to. We need, what does it look like when you haven't stimulated it at all? So that when you do those stimulation, you can say that it improved X% compared to non-stimulated. So that will help us do those experiments that I was talking about earlier involving deviatoric and dilational isolation. In the future, still have a lot of work to do on this, and a lot of it will involve understanding those mechanical properties of the gels, especially Poisson's ratios and the effects of fiber, because the idea that the material is completely isotropic is not completely true. So we need to understand that so we can better predict the deformations that we're going to apply, and hopefully use that to identify the beneficial limits of the shape and volume change in those gels. Okay. That was a lot, wasn't it? That was a lot. It felt like a lot to me. I'm exhausted.
Use the force.
Yeah. I got my guys with me.
Okay, there you go.
So now we're going to talk a little bit about my experience with massage therapy. And I never thought all the years that I spent going to massage therapy school would be so helpful. But Trevor saw it on my resume, and he's like, "John, I got the perfect job for you. This is going to be great. It's going to help a lot." So we're talking about an in vivo model, and we're mostly looking at the effects of iStim in an in vivo model. So that involves basically 3 steps. You got to make an injury that's the same in each one of the animals. You apply your treatment, the same to all the animals, and then you assess the healing. So pretty simple. There's been previous research done on this, and like I said, it works. It does something that's beneficial. But they're not really engineers. They don't have the engineering thinking as much, so they didn't really control. They just did the treatment the way that they learned it in the clinic. When you go in the clinic, they're like, "Oh, you're just supposed to kind of press about this hard. You got to feel for the adhesions with your hands, and gauge it based off of that, and see what your patient's telling you," which is all important. But we like numbers, so we want to know what the force is, what the frequency is that we're applying, and see a specific result as part of that. So again, that's our objective. Is there an effect of varying stroke frequency and force during the iStim treatments? Is there an interaction between the two? And hopefully we can determine and tell the physical therapist what to do as a result. So here's the little guys that I got to hang out with. They're about 1 pound, they're cute, and they're about 12 inches long. We had to perform surgeries on them, so there's one of those little baby MCLs. And you can see, I tried to put this here because this isn't the full length of it. It's like inserted there and then over there. And this is just for scale. This is like where we actually made the incision in the rat. And then we left the other side uninjured, so you can say at the end of the treatment, it healed to X% of the strength of the uninjured one. Because again, that variability between the animals, if you just injure both legs and then you say, try and compare them, certain ones will be naturally stronger than the others, so you have to compare it to its own native strength. What we used to actually apply the loads was this little device here, but we needed to be able to pick loads that we were going to apply and pick frequencies that we wanted to apply. So basically, we could have made a robot, but that would have taken a really long time and been very hard. So we decided to start with a simpler prototype, which was basically had feedback for the user. So you have a load feedback that tells you how hard you're pressing, and it also gives you an auditory feedback that's like a metronome that tells you you need to stroke down, you need to come up, you need to stroke down, you need to come up. So we validated that, and we could analyze exactly what we were doing in terms of force as well as frequency through grabbing these clustered points down here at the bottom and saying those are the points that we use to calculate our mean, as opposed to like you don't need to take all the time that you're not applying any force. And then you also would fit a sine wave, or a combination of sine and cosine waves, to the applied force line, basically, that you can see right here, and we can figure out the frequency that we applied at with that. And we found that we could apply between 0.3 and 5 newtons. 5 newtons was our max just because we were pressing on rats and they're a little bit fragile, so we didn't really want to press too hard, with about 12% error. We also, since we're using, it was just a uniaxial load cell, you can't hold it like this and expect to get any sort of reasonable readings out of it, so you can hold it at about 70 to 90 degrees, so it was when we were actually treating to get accurate data out of it. So we performed 6 treatments. The treatments were part of a 3-week package that included scented candles, therapeutic music, isoflurane laced with gas laced with lavender essential oils. They really, really enjoyed the treatments, had a great time. Treatments were very consistent. They were very pleased across each group. Question?
Yeah, since one sees that you need to make the incision and then do the uniform treatment.
Mm-hmm.
In your data, did you include all the rats, or did you write the first one or two off as training rats, so that?
What do you mean? Oh, well, we practiced before we did the actual treatments on other ones to make sure that we were consistent before we did that.
Okay.
So these were the actual treatments. So the force was a little bit harder to keep consistent. The frequency, surprisingly, was pretty good. It's like kind of playing an instrument. You can kind of like hum along to the tune of the iStim tool, and you just kind of flow with it. So despite the fact that they thought they were in a spa for 3 weeks, we actually had to kill them for science. And take their little legs and put them in these aluminum jigs and put the low melt metal in both sides to fixate them. Then we pulled them in tension to see what was the effect of the treatment that we did. And here's one of the ones that failed pretty good. So there's a little, oh wait, did it already pop? Yeah, it already popped. Where's the pop? There's the pop. So they're really tiny. We saw a small effect, but if you're a statistician, they would yell at us because it wasn't actually significant because we don't have a big enough sample size. We had pretty large standard deviations. But again, a lot of this research was just a preliminary kind of pilot study stage, so we'd have to do a much larger study with 60 or 70 rats to see an actual significant effect. So again, some more improvements we could make to this model would be that larger sample size, as well as controlling the animal's activity. And there's some techniques that you can use for that. I've seen people, they can basically hold the rats up so that they can't use the affected leg, and then they can put them on a treadmill for a certain period amount of the day and see if there's any interaction effects between iStim exercises that are an optimal amount. And we should also make a more physiologically accurate injury. When you go in and slice the MCL, unless you're getting in a lot of knife fights, it's probably not a very physiologically accurate injury. Well, more accurate would be some sort of a pull or a sprain type thing where maybe you're not completely tearing it, but you're getting close, so it's kind of just hanging there a little bit, like grade 2, grade 3 type of sprain. And then we would also want to measure histological and cellular changes in the ligaments as well, similar to what we would do in the in vitro. We could improve the device a lot as well. Definitely would want to put a triaxial load cell on there to get a complete force vector so that we know exactly what we're doing. And then a gyroscope would be useful to adjust that angle of application. So you can see, does it matter if you press straight up and down, or should you come in at like 70-degree angle, or should you come in at a 40-degree angle? Does it matter at all? So we can investigate those effects. That's all I got for you guys today. Any questions?
This is more about the beginning background of the actual thing, but it's just a question that came to my mind. They did the studies after the initial injuries. Have they done any studies on the effects of repeated ligament injuries,
Chronic, like in the chronic state?
If you've had it twice, how does that relate to not only the first but also the original?
Yeah, they like I said, they use it for everything, but some of those studies that I was referring to in terms of the ankle and shoulder were for chronic injuries. So they sprained it once, and then it just continues to hurt them for a long period of time. And people seem to get a lot of good benefit out of that because, I mean, that kind of gets into different stages of healing and whether your body's still in an inflammatory stage or not. But definitely people do use it for chronic, and they see results with that. Hit me. Anyone? Claire.
So your ice-down device, how deep does that actually have an effect on the tissue in terms of, so on those rats you're obviously looking at like a tiny little area that you have to penetrate to. If you go to the human level, is it actually going to have effects all the way through the tissue, or just on the surface fibers, or what's it?
That's something that people try to model as well. I've seen people try and do some sort of a FEA to look at tissue penetration that you'd see based off the force and the amount of pressure you're applying. And we weren't able to track that with our device that we made there, but that is an important thing to look at because, again, if we're talking about deformation, like if you would probably want to know exactly how much you're deforming the tissue in terms of the force that you're applying. So, yeah. Anyone else?
I was wondering if you've partnered with any sports med stuff or thought about maybe gathering data from them.
Yeah, we've talked a little bit with the physiotherapist at Idaho Sports Med, and they were pretty interested in the research that we're doing. I've also talked with another physical therapist in the Valley, and they're all very interested in the dosing effects because they just kind of learn what they learn at the seminars and they don't really know. So that's definitely something that we would consider doing in the future, working with physical therapists.
I have a question about the in vitro analysis that you done. Over there you said that the hypothesis you had was that the dilation would not affect the healing as much as the shape changing force applications, right? Is that a theoretical procedure you follow to come up with the hypothesis, or are you just testing that right now?
We're mostly just testing that right now. Like I said, the main reason for it is those 2D monolayer studies with the fluid shear. There's in your body with those tissues. There's, especially in ligament, when you stretch them, fluid leaves the tissue and it contracts a lot. So there's definitely probably a role to play with the fluids affecting the shape of the cells. So that's why we think that it's mostly shear based as opposed to dilational based. Justin.
So for a practical application of what you've learned already, for somebody who's experiencing a ligament injury, after the initial healing phase, what would you recommend as the next step in performing healing, and can you get it back to 100%, or how far can you get it?
Like I said, there's a lot of confounding factors in it, but definitely the most important thing is you have to provide stimulus to it in small dosages. You don't want to basically push through the pain and tough it out because you can just end up getting a re-injury. But if a small amount of pain is happening in the injury, you can probably still give a little bit of stimulus so your body knows to heal. It's all dosage dependent in terms of that stimulus that you apply. So if you've had sort of an acute injury, there's a stage where you definitely should immobilize it. But as soon as you can start moving it, you should be wanting to move that joint to let your body know that it needs to continue to heal. And that's what people are seeing, and that's what's becoming more and more popular, especially, I know me and Don and Trevor and Claire all went to the football players' physical therapy rehab center, and they have them in the pool within 2 days of the injury, trying to move, trying to stimulate those tissues. So that's clearly one of the most important things you can do, is just to continue to try and use it. And a lot of people don't like to, they think, in terms of like weeks and months of healing. When you have a ligament injury, like you're gonna be healing that thing for 6 months before you might not think about it all the time, and then after that, it still might nag you a little bit, but you have to be careful and consistent with the stimulation you apply to it to really get it to fully heal.
Is what you're looking at specific to the MCL? Because, so the healing properties between, say, ACL and MCL are very different. And is that, do you think, because of the location and the loading condition?
I think so.
Very close to, and would this help? I know it's obviously not terribly practical to do on an ACL, but what are your thoughts on that?
Well, as far, I don't know this for sure, but if I had to give my thoughts on what it is when you have, there's clearly certain tissues that are more surface level that you can get at, and a lot of those are highly aligned along a single axis, like your Achilles tendon or into your MCL, those types of ligaments. I would think that perhaps because those ones are just aligned along that one axis, but providing that shear stress is more beneficial because you can be telling them to align along that one axis as opposed to those more amorphous tissues. Maybe the stimulus that they need is different because they're experiencing different stimuli on a regular basis from a bunch of different directions.
The ACL doesn't get blood as much blood.
It's just true, yeah.
It's in your foot cavity, so it doesn't feel like it.
So don't hurt your ACL if you can avoid it. Good advice. Yeah. If you take anything away from the frustration, just don't leave your house. Just ligament injuries are bad. Just stay at home.
So I know this isn't what you all are working on, but you're talking about quantifying healing from like a genetic perspective. So are people looking at like genetic intervention as a way to like convince injured ligaments to behave like healed ligaments, or what was that?
I mean, just by sending a different chemical signal and stuff. Yeah, that's a pretty huge thing, and that's kind of goes back to like the cell therapies and stuff like that. And I mean, they can use in vivo models and in vitro models for that as well, just to put a different chemical or different protein in there and then see what happens. So, but that type of stuff just takes a long time as well to figure out. But I'm sure, I don't know, maybe we'll invent some sort of steroid for ligament healing, and then we can all just tear our ACLs and be back in 3 weeks. Anyone else?
Let me ask you that.
Yeah.
This is a very uneducated question because I have no knowledge of biomechanics. I'd like to know if the healing occurs due to the mechanical properties of the cell itself, or because the body, the DNA generates a signal to actually make the cell, to have the cell heal.
It's the actual response is from the cell itself. It has like I talked about, the stretch activated channels that release different ions, and then the cells move around, and then they produce more extracellular matrix in the structure that reduces the stress state, basically.
I mean, it's just like a follow-up question to the previous question, because if it is the body that's making it heal, then you essentially are restricted if you're just applying mechanical loading, because you're essentially just stimulating the cell and not the body, not the chemicals.
Yeah, it's true. There's definitely probably an interactive effect between the growth factors that you'll get from the body as well as the straight cellular response that it gets from the mechanical load. But you would have to isolate those and first figure out what their baseline is, and then look at those combined effects.
Hey, let's get